Thank you very much for the kind invitation to be here with all of you, albeit virtually. So, I will. So these are my disclosures, and before I go into the details of the ABC6 guidelines, I would like just to make a short introduction to explain a change that has occurred with ABC. So as you are, I think, familiar, we have created this effort more than 10 years ago when we started with a task force. Then in 2011, we had the first ABC conference. And at that time, it was a project from the European School of Oncology, from ESO. And from ABC2 on, Esmo has also joined the effort. And so these have become the ESO-ESMO guidelines for advanced breast cancer. And this has been the case up until ABC5. And when we, in 2019, when we finished the ABC5, I have explained to everyone that ESO could no longer continue to organize the conference, and that in principle, the organization would go to ESMO. Unfortunately, that has not happened, and ESMO has decided to leave the effort and to have their own set of guidelines for metastatic breast cancer. And so we have organized the ABC6 as from the actual legal entity that is behind the conference and the guidelines, which is the ABC Global Alliance. Because of the pandemic, ABC6 took place as a virtual meeting, as so many other meetings are having this difficulty. Nevertheless, we had about 1,000 participants from 67 different countries. And important for you to know, all sessions are still available in the conference platform until April this year, and you are able to share and listen to all of them. There were excellent talks, and the manuscript that summarizes the guidelines and the consensus session is under preparation, should be out soon. So, as I was saying, the guidelines are now ABC Global Alliance developed, but they have either endorsement or official representation of many organizations that you see there. And for the first time, we also had NCCN representative, but also we continue to have ESO, ASCO, the German and the French guidelines, ESTRO, EUSOMA, EONS, European Cancer Organization, and CIS, and some other organizations either provide their support or auspices to ABC6. And you can see here from the panel members, the consensus panel members, many of them representing important organizations that have joined us in this effort to develop international guidelines. And you can see here that India was represented by Dr. Smutri Kupikar. So to clarify the situation now, we have many important guidelines for early breast cancer. Mentioning just a few, we have ASCO, we have NCCN, we have some national guidelines as well. As examples here are France and German. We have the ESMO guidelines for early breast cancer, and we have the consensus of St. Gallen, also an important set of guidelines for early breast cancer. So from now on, for advanced breast cancer, we have the same type of guidelines that we have for early breast cancer. We also have the new ESMO guidelines for metastatic disease, but we will continue to have the Advanced Breast Cancer International Consensus Guidelines. And why? Because these are really different. They are truly patient-centered. Patients are treated as peers. These are consensus-based, not just written by a group of authors. They try to be as global and international as possible, as well as practical. And they can be both adopted and adapted in many or all countries of the world. For that, we have a special type of meeting that we call Best of ABC in your region or your country. Examples that we have already developed is the Best of ABC in Latin America, the Best of ABC in New Zealand. And what we do in these meetings is with a consensus panel of regional or national experts, we go through the guidelines and we see which guidelines can be adopted, which others must be changed slightly, and then we develop the adapted ABC guidelines to your region or country. So I leave a suggestion to you that perhaps we could do a Best of ABC in India with a consensus panel of Indian experts on this subject. Now moving to the new guidelines and the new statements of ABC6, I will, of course, be very brief and just tell you some take-home messages, and then you will be able to read more carefully all the details in the manuscript. So we revised some definitions. In particular, an important definition that was revised was endocrine sensitivity or resistance. A point to know is that resistance is a continuum. So there's never 0% resistance or 100% resistance. And this is important more for clinical trials to have homogeneous populations defined more than in clinical practice. But the previous definition, in our opinion, led perhaps to a misinterpretation by some of the clinical trials developers and was excluding from clinical trials a group of patients that we do not believe that they should be excluded. So we tried to improve and simplify the definition. And for primary endocrine resistance, it is now defined as a relapse while on the first 2 years of adjuvant endocrine therapy or progression of disease during the first 6 months of the first line of endocrine-based therapy for advanced disease. And all the other situations we consider secondary or acquired endocrine resistance, with one exception, and that is the endocrine naive population. So de novo metastatic disease, where endocrine therapy was never used, and we don't know if there is sensitivity or resistance. A new definition that has emerged from ABC6, and I will not go into the detail, but it's a problem that is becoming recognized as well as research in depth to try to understand the mechanisms. And this is what we sometimes call oncobrain, or cancer and treatment-related cognitive impairment. So we all have patients that say that they have memory loss, the difficulty in concentrating, and this is very much recognized as a problem now. It is linked to both the disease and the treatments. The mechanisms behind it are not totally clarified, but they are probably multifactorial and also associated with other symptoms. And the fact that we define this as a problem allows us then to define also the management as well as research associated with this topic. Now, a topic that was very intensively discussed was oligometastatic disease. So let's start with the definition. Basically, the definition has not changed much. It is considered a low volume metastatic disease in terms of limited number and limited size of the metastatic lesions. They don't have to be in the same organ, more or less up to 5, but of course, this is not a miracle number, so it can be 6 or it can be 4. And of course, the definition of oligometastatic depends on the imaging that you are using. If you do your imaging just with X-rays and ultrasound, you will not define oligometastatic the same way as if you do a PET CT or whole body MRI. So the imaging method is clearly linked to the way you define oligometastatic disease. One particular situation that we define separately is if you have isolated relapse in the contralateral axilla. And so the first thing to do is to make sure that you do not have a new primary in the contralateral breast. And if you are certain that there is no second primary, then this is metastatic disease. However, because it is quite isolated, and you can treat very similar to an early breast cancer and achieve even perhaps a cure or a very long survival with a multidisciplinary approach, we consider that this is a particular setting within the oligometastatic disease. Now, what about management? So here we emphasize the need for a multidisciplinary discussion and a multimodal approach. And the aim of this approach should be potentially curable, although we can never promise that in fact this is what we will achieve. The second important message is that we must start with the systemic therapy first. And based on the response to the systemic therapy, then decide about the local regional treatments, be it surgery for certain metastases or radiation or radiosurgery or a combination of several of these treatments. The only exclusion to this note that I'm giving you is brain metastasis, that I will dedicate a special part of my talk to that. Now, we have a small randomized phase 2 trial with different types of cancers where there were only 18 breast cancer patients that evaluated stereotactic radiotherapy and showed a significant overall survival benefit. But we must have more trials and trials dedicated to breast cancer to have a strong level of evidence. In terms of clinical trials, just something that I leave out there for us to perhaps think about and discuss in the future, that the way we are developing drugs or new drugs, always aiming at the maximum tolerated dose is probably not correct anymore. And with the new agents, we should aim at the minimal effective dose, what is necessary to block the target, and not maximizing the dose, because it ruins the possibility of having a targeted agent that is less toxic. Because if we push for the maximum dose, even a target agent will become quite toxic. Now, in terms of survivorship issues, we started to discuss something that is really under a lot of discussion in Europe. I don't know the situation in India, but this is the need that caregivers, the needs of caregivers, the need for support for both formal and informal caregivers. Because of lack of time, I'm not going to go into the details, but just to let you know that this is a very much a situation of need in many countries around the world. Now, passing to another section that also led to a lot of controversy and discussion is what do we do with the results of a biopsy of the metastatic lesion? So first of all, of course, I think we all agree that the biopsy should be performed at least once, and that we should look into at least estrogen receptor and HER2, at least once in the metastatic setting. We emphasize here that it's mostly or almost exclusively estrogen receptor and HER2 and not progesterone receptor. Is not really important in the metastatic setting, except to prove that it's really a triple negative. But because the existence of ER negative, PR positive is very controversial, and for many pathologists, they do not believe that it exists, but it's a technical issue. So we think that PR is not of value for the metastatic disease. Now, what do we do if the results of the metastases are different from the primary tumor in terms of biomarkers? So we all know that it's going to be very difficult to have a randomized trial saying we follow the results of the primary or we follow the results of the metastases. So what we recommend, already recommended that before, is that if you have ER positive in the metastasis or in the primary, that you should and you can try ER-based therapy. And the same for HER2. If it is positive in the primary or in the metastasis, you should also try anti-HER2 therapy. Now, what can we do if you have a confirmed triple negative in the primary, but then in the metastasis, you have ER positive or HER2 positive? What should we do? Or the other way around. If you had a ER positive, then you have a confirmed triple negative in the metastasis. What should we do? And this recommendation is because we now have drugs approved exclusively for triple negative. For example, some types of immunotherapy and sacituzumab govitecan. We believe that this situation where you have approved triple negative, be it in the primary or the metastasis, you should also be able to give or to try these agents approved for triple negative disease. Now, going into the different subtypes, for ER positive, HER2 negative, there is really not a lot of new statements because everything had been extensively discussed in ABC5. So there was an update of the scores of the Esmo magnitude of clinical benefit, which I will not detail. And also a note regarding the use of alpelisib where it is available, that we consider, because of the huge survival benefit of the CDK4/6 inhibitors, that endocrine therapy and the CDK4/6 inhibitors should be considered the standard of care for first-line therapy, and that the use of another endocrine therapy agent, an alpelisib, should be reserved for the second-line setting if there is a PIK3CA mutation in the tumor. And of course, if you have access to this treatment, for example, in my country, we don't have access to this treatment. Now, there were also presentations of trials, particularly the PEARL trial and the Young PEARL trial, where endocrine therapy and palbociclib were compared to capecitabine. However, these trials had some problems, which again, I don't have the time to go into the detail, but I'm happy to answer questions. And because we have never seen the survival benefit we see with the CDK4/6, particularly in the first line setting, and we have never seen that with chemotherapy, we continue to consider as standard the use of endocrine therapy and the CDK4/6 inhibitor and not chemotherapy in the first line. For the HER2 positive disease, we have a new drug that is gaining more and more relevance where available, which is trastuzumab deruxtecan. And because now we have the results of the trial in second line, head-to-head comparison with T-DM1, with a very substantial PFS benefit, not yet the final OS benefit, but a trend. Most people believe that trastuzumab deruxtecan will take the place of T-DM1 as the preferred treatment option after trastuzumab and pertuzumab. Attention to the problem of ILD pneumonitis with these agents. So if we don't use it in the second line, although the level of evidence is lower, we can also use in later lines of therapy because of the Destiny-01 results. For those patients who don't have access or have contraindications to the deruxtecan use, T-DM1 remains the preferred second line or even beyond second line for the countries where you don't have access to deruxtecan. We also have a very good combination, which is tucatinib, trastuzumab, and capecitabine that had a benefit in survival, not a very big benefit, but still 4 months benefit in survival. And that was particularly interesting in the fact that it also had an activity against active brain metastases, which was not the case in other trials. So this is also a good option. Usually we reserve it, or if we have availability for everything, reserve it for example, third line setting after T-DXd, even though we don't know the efficacy of these agents one after the other. For triple negative disease, we had the confirmation of the results, and in this case of overall survival results for pembrolizumab combined with a taxane or with carboplatin for PD-L1 positive triple negative disease. In countries where atezolizumab is available, it's also an option if combined with nab-paclitaxel. But to be honest, I don't see very much a reason to use atezolizumab with nab-paclitaxel, since it is much more expensive when we have a more straightforward result without any confusion in terms of the benefit with another agent, unless you don't have access to pembrolizumab. And we are starting to have still very few countries have access to sacituzumab govitecan, but when approved and available, it is a very good option from second line on for the triple negative setting. For hereditary breast cancer, a couple of new notions. So we all know that the strongest evidence is for germline mutation, BRCA1 and 2, and these are the ones that have clinical utility and therapeutic impact. However, some other genes are becoming to be important in this field. And for example, for the use of PARP inhibitors, we have data from a small phase 2 trial that, for example, olaparib may also work in somatic BRCA1 and 2 mutations and germline PALB2 mutations. And these are important notions to take. And therefore, for both germline, somatic, or BRCA and PALB2, a PARP inhibitor such as olaparib or talazoparib is one of the preferred options for triple negative disease. What about sequence? So if we have a ER positive, BRCA positive advanced disease, the recommendation is that endocrine therapy and CDK4/6 inhibitors should be the first line treatment, and we should use a PARP inhibitor after that. If we have triple negative, PD-L1 positive, and BRCA positive, then the optimal sequence for the majority of cases would be immunotherapy and chemotherapy first, and then PARP inhibitors after. However, here, there might be situations, for example, limited burden of disease, where you can go with the PARP inhibitor first and then the immunotherapy second. In terms of biomarkers, I will only mention one that there is some differences, which is the ESR1 mutation. And what we know from ESR1 is that it becomes more important after exposure to aromatase inhibitor. And in the case of existing mutations in ESR1, we should avoid using another aromatase inhibitor. It might not be the best choice. So either fulvestrant or tamoxifen or one of the new oral SERDs maybe in the future will become important. However, we still do not know how to follow, and we cannot yet recommend to do serial measures of ESR1 mutation. There was the PADA study presented in San Antonio, which is one of the first showing that perhaps we can change our treatment by monitoring ESR1 mutation, but it's still pending a lot of discussion and confirmatory studies. Now I'll spend a couple of minutes on the update of symptoms to treat locally advanced inoperable disease. In the context of these recommendations, we are talking about inoperable, locally advanced, not large operable. These are early breast cancer, but these are inoperable, but that do not yet have distant metastases. So in that case, we can have a situation of a fast-growing aggressive tumor or a neglected, slowly growing tumor. And this can be de novo or relapsed, and it can be inflammatory or non-inflammatory. But what we know is that there is always a high tumor burden. However, the biology may be very different. And this makes this situation quite complex. It's somewhere in the middle of early and metastatic, and we have very few dedicated data, and some recommendations become very difficult. For example, PD-L1. So how do you consider this situation? As early breast cancer, where PD-L1 is apparently not important, or as metastatic, where PD-L1 is important for indication of treatment? So this is an open question. In here, what we recommend is always start with a biopsy, evaluation of histology and several biomarkers, and then also have a full staging. That means complete history, physical examination, lab tests, and some form of imaging of chest, abdomen, and bone. In countries where it's possible to have a PET-CT, if you have a ductal invasive carcinoma or non-special type, then PET-CT, if available, is preferred. You can do a very good total imaging with that. But if you have a lobular invasive, in that case, PET-CT might not be the best, and CT scans and bone scans are preferred. Now, in terms of treatment, we should start with systemic treatment. And again, it is a situation where multidisciplinary approach is key and indicated before we start the treatment, so that we look at the possible sequence of treatments. For ER-positive, HER2-negative, locally advanced disease, we can either start with a chemotherapy approach, anthracycline and taxane, or with an endocrine therapy approach. Just like I told you in the beginning, we can be in the presence of an aggressive, rapidly progressive luminal B-like disease, or we can be in a neglected, slowly growing luminal A-like disease. And there will help us the choice between chemotherapy or endocrine therapy, CDK4/6, and we should take many factors into consideration when deciding. For triple negative disease, chemotherapy is what we should start with, anthracyclines and taxanes, and almost always, if possible, add a platinum. Attention to the toxicity, and this should be independent of the BRCA status. For the addition of pembrolizumab, there was a lot of discussion, but in the end, the panel decided to go with the indication of the biomarker more similar to early breast cancer. Like I explained to you, it's very difficult. So do we indicate pembro when PD-L1 is positive or independent of PD-L1? And this is something that the panel chose to vote this way, but it's of course controversial. Now for HER2-positive disease, taxane and anti-HER2 therapy, and in this case, a dual blockade with trastuzumab and pertuzumab. What about adding anthracyclines? When the panel voted, this was the only statement without a consensus. However, during our discussion and reminding everyone that we are talking about inoperable disease, then we asked the audience to vote, and 70% recommended that anthracycline should also be a part of the treatment of locally advanced inoperable HER2-positive disease. Now, for how long do we use the anti-HER2 therapy? If we have a complete remission at the time of surgery and local regional management, then we suggest to go for 1 year of the trastuzumab pertuzumab that we started with. If we do not have a complete remission, then the recommendation is to change to TDM1. Again, you see here that recommendations are mixed between early breast cancer and metastatic breast cancer, because we don't have specific trials only for this locally advanced inoperable breast cancer. Also, in the middle of early and metastatic, we say that in the case of a locally advanced inoperable that has become operable, we can add, if accessible, 1 year of adjuvant olaparib, if there is a BRCA alteration. If the locally advanced inoperable disease remains inoperable after systemic therapy, palliative mastectomy should not be performed unless you want to control any local symptom, and this is clearly not the best way to do it. It's much better to go for radiation, and if it's still inoperable, then start to treat as metastatic disease. If it becomes operable, for the majority of cases, it will be a mastectomy with axillary dissection, but there are situations where breast conservation is possible, and there are situations where even a sentinel lymph node might be possible. In terms of inflammatory breast cancer, the recommendations are very similar in terms of systemic therapy, like I just described. We do need trials dedicated to inflammatory disease, and there is a worldwide consortium, as well as a research foundation dedicated to this type of breast cancer. In terms of surgical or local regional approach, there are differences. Here, mastectomy and axillary dissection, even in the presence of a very good response to systemic therapy, must be done. And it's probably the only situation where immediate reconstruction is not recommended. And we must have a local regional radiotherapy, even if a PCR was achieved with systemic therapy. Now, last point I wanted to take a few minutes is regarding the management of brain metastases, and in particular, the brain metastasis of HER2-positive disease. For this first statement, we on purpose ask the panel to revote. This statement is in the ABC guidelines for many years, but because we have new treatments, particularly for HER2-positive disease, we wanted to know if people have changed their mind regarding asking for brain imaging without symptoms. And as you can see, the vast majority of the panel still considers that we do not go and screen the brain, but that we must be particularly attentive to any symptoms that sometimes are subtle symptoms and perform a brain imaging if we have any suspicions that brain metastases exist. Now, for the HER2-positive disease with brain metastases, if we have brain metastases and otherwise stable disease outside the brain, then we should treat, usually with stereotactic radiation, and we should not change the systemic therapy. We keep the same systemic therapy. If we have a relapse in the brain as the only site of relapse, also treat locally, and there is no benefit in starting or restarting chemotherapy at this time, but there is a benefit to restart trastuzumab if it has been stopped. Now, because of the data of tucatinib, it's also possible to, at this point, start tucatinib, trastuzumab, capecitabine. However, the majority of the panel would prefer to reserve this treatment at the time of progression in the brain. There is also activity in the brain from TDM1, albeit not a very big activity, but there is. So if you don't have access to anything else, TDM1 is also a possibility when there is progression in the brain. Now, here, as I was saying, if there is progression in the brain metastasis as a major site, then tucatinib, trastuzumab, capecitabine is the best available option. TDM1 if you don't have, or any other systemic therapy if you don't have access to either one. So last point to tell you that, as usual, we went through some important side effects. We have guidelines on how to manage oncobrain and also how to manage ILD pneumonitis, not just the one related to trastuzumab deruxtecan, but also remember that many of our agents can give pneumonitis, like mTOR inhibitors, PIK3CA inhibitors, immunotherapy, and even CDK4/6 inhibitors. Final slide to tell you that there are a lot of interactions between these new agents and treatments that we use very often for other problems that the patient may have. For example, PPIs like omeprazole, lansoprazole, and CDK4/6 inhibitors, there is a negative interaction with decreased efficacy of the CDK4/6 inhibitors. So I would like to thank all the scientific community members of ABC6, all the patient committee members of ABC6, and all the Global Alliance Board of Directors, and also to everyone who has provided us important support, and leave you with 2 dates. So if COVID allows, we would like to have a special edition of ABC this year in November in Lisbon to meet face-to-face. And if not, we will have our normal ABC7 from 9 to 11 November next year, 2023, and I hope many of you can visit us in Lisbon. Thank you very much.
Thank you very much, Dr. Fatima.
To my own questions, there are 2 questions in the chat box. One is regarding the brain metastasis. So if, say it's a TNBC with a solitary brain metastasis, which has been dealt with by local therapy, would you then advise systemic therapy in those patients or wait for the systemic relapse?
So as I think I mentioned in the guidelines, we do not recommend to give chemotherapy as a adjuvant, like the question asks. So, but we do recommend, because there are data, that you restart trastuzumab, because there is a benefit in survival. For how long should you give that trastuzumab? We don't know, but at least you should give it for a year. If after a year there is still complete remission and no disease anywhere, you may consider stopping.
So that was an important point that you brought up, is the continuation of the anti-HER2 therapy in the metastatic setting. So, for example, you have a systemic metastasis and you're using the dual anti-HER2 therapy. And, after, say, a period of 3 to 4 years, the patient is in complete remission. What do you really do in practice when you're faced with that situation?
So when we have a very long complete remission, there is my practice. So this is not based in very strong data, because we don't have very strong data, but I tend to stop the pertuzumab first and to continue. Let's say that after 2, maximum 3 years that you have a complete remission, I drop the pertuzumab and continue with trastuzumab alone. And then with the trastuzumab, I actually see with the patient, there are patients who become so anxious if we stop everything, but there are others that really want to stop. So nobody knows exactly what is the best duration. But after, I would say that even if I wouldn't have problems of access, when I reach 5 years, I really think that it's time to stop. It's similar to what we think of endocrine therapy, right? At some time, you need to stop.
The second question is about, these are all from the chat box before I come to my own questions. This is regarding the current status of local therapy to breast and axilla in oligometastatic HER2 positive advanced breast cancer. So is there a role for whether it is surgery, radiation, or both?
So the idea of the definition of oligometastatic is, like I said, try to be as curative as possible. So in those situations where you have a de novo oligometastatic, then you have to treat the primary and also the metastases. And so the recommendation on how to treat the primary is forget that there is a metastasis. So pretend that this is an early breast cancer patient. And so you treat with a systemic therapy, and then you do a proper surgery and proper radiation according to the early breast cancer guidelines. And then you add the treatment of the metastasis.
Then, of course, there is one other question, and this is regarding the PET-CT. As we know that, lobular carcinoma often is, very low SUV on PET, and, sometimes things can be missed. So what is your take on this?
So that is why we added an extra statement by saying that if you have a ductal invasive carcinoma, then PET is a very good option, because in one exam, you can do all the imaging instead of doing several. But for lobular, it is preferable to do the CT scans and the bone scan. And you will still see that in some situations we still miss and we cannot see properly the metastatic disease. For example, peritoneal carcinomatosis, which was something I didn't include here, but that we discussed in ABC6, it is very difficult to see, even in a CT scan or a PET scan or even an MRI. Sometimes you cannot see the carcinomatosis, but you just see the ascites. So we need to develop better imaging techniques to be able to see the carcinomatosis.
So the next question is about rebiopsying in the metastatic setting. And, there are a lot of problems that the clinician is faced with when, as you mentioned, and, so rightly mentioned in the guidelines as well, there is a change in the receptor status. So coming back to the issue about TNBC and the change in the receptor status once you rebiopsy, then in the sequencing, would you sequence, considering, the very good therapies you have for TNBC, would you put them first, or you would put the ones first which are related to the new receptor that has been discovered? I know these are rare situations, but you do face them, and then you're at a crossroad.
Well, I don't know the answer to that question. I think nobody knows, right? But what we wanted to say in the guidelines, because of countries have different rules for reimbursement. And in some countries, if you show a pathology report that has a ER positive, then you can no longer have access to, for example, sacituzumab or immunotherapy, right? And what we were trying to safeguard is that if your primary was confirmed, so you make sure that you revise and that there is no technical problem, and that it was really a triple negative, that you can have access to that treatment. For example, in the ASCENT trial with sacituzumab, they analyzed patients who had tumors triple negative as primary and then became something else, or that had something else as primary that became triple negative in the metastases. And they analyzed these two subgroups because they were allowed in the trial, and the benefit was very similar to the two. So it seems that sacituzumab is beneficial if you have a triple negative in the primary or a triple negative in the metastasis. So that was our idea, is to make sure that you can use. Which one you use first, I cannot answer that question smoothly. I have no idea. It is really up to you, up to the tumor burden, how much disease you have, how much symptoms, and also, of course, the cost, because all these agents are so costly, right?
So the next question is, again, relating to biopsies, and, NGS has become a very common, investigation in other solid tumors, especially in lung. Where do you put the place, or where do you place this in the setting of breast cancer? When would you really ask for an NGS?
I don't.
Yes, it's good that you...
I don't ask, because I don't think so. The trials we have not shown a big benefit of doing NGS, but I am convinced that we should develop a breast cancer specific panel, because we already have at least, let's say, about 10 markers and biomarkers that we can use and that are actionable, that we can perform something based on that. So maybe instead of doing an NGS panel, we could do a breast cancer panel. And I think you know that there is a SCAT scale from Esmo, and the SCAT classifies the biomarkers. And clearly, only the ones that are in tier 1 and some in tier 2 are the ones that you can use. And in breast cancer, basically, it's ER, HER2, BRCA, PIK3CA, perhaps ESR1, the HER2 mutation. Then we have, not in the genes, but in the immunohistochemistry, PD-L1, and everything else. We don't have anything, we can't use anything else for us to take a decision. Perhaps PAL-B2, but why would we ask an expensive test if we don't know what to do with the results?
Yes, I think that's a very important point, and we wanted to bring this out because people do tend to ask for NGS in breast cancer. So that was a very emphatic no for that. And then, of course, I think we are running short of time right now. So I think thank you, Dr. Cardoso, for an excellent overview of metastatic breast cancer.
Perhaps,
I always consider it as an art of, treatment, putting all together so many complexities, and your ABC guidelines have really made it simpler for the clinician to navigate all these complexities.
thank you so much.
Absolutely.
It was a pleasure.